It's all yours.
Hi, everyone. Yes, thank you, Steve, for your kind introduction and for your organization. Thank you for all the sponsor, and thank you for all and welcoming for our colleague from everywhere. Good morning and good evening. Today we'll discuss and present case series about the link between cancer and peripartum cardiomyopathies. Shall we start, Steve?
Yes, please.
Yes, thank you, Okay. Women with history of Hodgkin lymphoma and peripartum cardiomyopathy, gray zone diagnosis. This is me, Prof. Hasan Farhan from Iraq, Baghdad Heart Center. I'm senior consultant cardiology, and recently I'm qualified ICOS certified cardio-oncologist, Iraq Scientific Council of Cardiology, and really we have established our cardio-oncology program 2 years ago, and we are very lucky and to collaborate. Okay, do you hear me? Is the voice clear? Sorry.
Yes, clear.
Okay, the voice is clear. Okay, thank you. And the slide, I think it's clear. Okay.
Yes. Okay.
Thank you very much. Background: a recent study showed that the prevalence of cancer is 5.1% in patients before their diagnosis of peripartum cardiomyopathy. Comparing with age-matched women without peripartum cardiomyopathy, the prevalence of early onset cancer in peripartum cardiomyopathy is 16-fold higher, and the risk of cancer before the diagnosis of peripartum cardiomyopathy is 9-fold higher. However, data about the risk of subsequent pregnancy in patients with history of cancer and peripartum cardiomyopathy is very limited. Among 70 patients diagnosed with peripartum cardiomyopathy at Baghdad Cardio-Maternal Clinic since 2015-2019, we reported 2 patients with history of Hodgkin lymphoma before the diagnosis of their peripartum cardiomyopathy. We followed up them during their frequent subsequent pregnancy after the diagnosis of peripartum cardiomyopathy with 2 different scenarios. So we will share with you the 2 scenarios for 2 patients with the history of Hodgkin lymphoma and later on peripartum cardiomyopathy. Regarding the first case, a 25-year-old single female diagnosed with Hodgkin lymphoma in 23, treated with 6 cycles of chemotherapy, including anthracycline. After 7 years, she got married and delivered her baby in 2010, 11, and 15, all with normal vaginal delivery. So she got 3 pregnancy. 18 weeks postpartum of her last delivery, she was diagnosed with peripartum cardiomyopathy, and LV ejection fraction was 35 to 40% initially, and subsequent echo did not show recovery of LV ejection fraction function. Two years later on, at the age of 40 years old, she presented with a new unplanned subsequent pregnancy of 8 weeks gestational age with NIHA class 2 symptom. Echo showed LV ejection fraction was 45% and GLS was minus 90%. She was on metoprolol tablet, hydrochlorothiazide, and lisinopril. Her medication were stopped and was kept on bisoprolol 2.5 milligram daily. On June 2018, she delivered a 2.9 kg full-term healthy male baby. 4-month postpartum, echo reveal ejection fraction was 45 and GLS minus 12.8. So we noticed a reduction in GLS from the initial reading. It was minus 19, and after 4 months of postpartum decline to the minus 12. She was on metoprolol, lisinopril, and hydrochlorothiazide. Again, 2 years later, she presented with 7-week gestational age subsequent pregnancy. ECO showed ejection fraction 40, GLS minus 40.5%. The decision of pregnancy heart team at that time was to terminate the pregnancy. However, the patient refused to terminate the pregnancy as a result of the fetal heart sound was positive. At 36 weeks gestational age, she delivered a full-term healthy baby with an eventful normal vaginal delivery. Ejection fraction and GLS 2 days postpartum were 48% and minus 13.9 respectively. She was kept on bisoprolol and lisinopril. At 2-month follow-up postpartum, she informed us that she didn't take any medication postpartum in order to breast her baby. New echo showed ejection fraction 44% and GLS minus 12.3%, and anti-failure was reinitiated with patient education to optimize her adherence to drug therapy. At 6-month follow-up, echo showed the same measurement. This is about the case, first case. The other case we presented, an 18-year-old single female diagnosed with Hodgkin lymphoma in 28 and treated with 6 cycles of chemotherapy, including doxorubicin, cumulative dose 317 milligram per meter square. In 2011, she got married, and in 2012, she delivered her first healthy baby. In 2014, the patient diagnosed with hepatic involvement of Hodgkin lymphoma, treated with 16 doses of doxorubicin, a cumulative dose 343 milligram per meter square, making the total cumulative dose equal to 660 milligram per meter square. Two months after completing her chemotherapy, she got a pregnancy at the beginning of 9th period, and she developed dyspnea and delivered a healthy twin baby at home with an eventful normal vaginal delivery. 2 weeks postpartum diagnosis with peripartum cardiomyopathy with initial ejection fraction was 25%, severe LV dysfunction. 11 months later, her echo showed ejection fraction 55, showed a recovery of her LV function, and GLS minus 19, first documented LV ejection fraction recovery. 2 years later, she delivered a 3-kilogram healthy female with an eventful normal vaginal delivery, again unplanned subsequent pregnancy, and her ejection fraction 60, and the GLS was minus 80%. No medication was administered during pregnancy. Finally, 2019, she got a second subsequent pregnancy. Patient was kept on bisoprolol. She delivered healthy full-term female baby with normal vaginal delivery. Ejection fraction at that time 61%, and the GLS minus 18. No hospital admission required during her pregnancy. So, in summary, we have two cases with history of Hodgkin lymphoma and peripartum cardiomyopathy. The summary of first case, 25 years old, diagnosed with Hodgkin lymphoma. The initial or the total cumulative dose of doxorubicin is unknown. After 7 years, delivered the first and second and the third baby. After 18 weeks of her last third pregnancy or third delivered baby diagnosed with peripartum cardiomyopathy, ejection fraction was 35 to 40%. After 3 years, delivered a boy with ejection fraction was 48, 49, and GLS minus 11.6. After 7 months, pregnancy with 7 weeks gestational age, ejection fraction, it was 48, and at 9 months period delivered male with her ejection fraction 44. So this is the first case. She's diagnosed as case of lymphoma, get 3 pregnancy with the 3 baby, and then diagnosis as peripartum cardiomyopathy, and subsequently there was no LV ejection fraction recovery or improvement. And the big question here is her subsequent LV dysfunction, whether related to the initial anthracycline or chemotherapy related LV dysfunction, or it's an peripartum cardiomyopathy, and that's the question. Regarding the second case, as we did mention before, 80 years old diagnosis with Hodgkin lymphoma. Cumulative dose, we have the cumulative dose of doxorubicin, 317 milligram per meter square. After 4 years, delivered first pregnancy. After 2 years, diagnosed with hepatic involvement, make the cumulative dose for the second relapse for hepatic involvement 343 milligram per meter square. After 1 year, delivered twin. Again, twin is stressful pregnancy. She got pregnancy 2 months post completing of chemotherapy. After 2 weeks, diagnosis with peripartum cardiomyopathy, and initial ejection fraction was 25%. After 11 months, recover, and this is the great chance to recover from severe LV dysfunction to the full recovery, and the ejection fraction was 55 and the GLS minus 19%. After that, she got 2 pregnancy. This is simply the summarize of 2 cases presented in our daily practice with history of Hodgkin lymphoma and with subsequent peripartum cardiomyopathy, and again with subsequent.
Thank you, Dr. Farhan. Yeah, thank you, Dr. Farhan, for really interesting cases. This is Dan Lenahan from St. Louis.
Hi, Dan.
Hi. Especially the second case, was there ever any consideration of using desoxane? But it looks like she tolerated that larger dose of anthracycline okay.
Yes.
Because I mean, I think most of the time
this is a very important question from record. Actually, there was no use of doxorubicin. It's not used at all at that time. Having this drug to be used in order to protect the LV dysfunction without any use for any further drugs.
Yeah. So there's a weird dynamic that happened over the past 20 to 25 years. That initially the desoxane appeared to be quite cardioprotective and was being used in many places. And then they had 2 breast cancer studies that came out in like the late 1990s. And one of them suggested that desoxane may impair the efficacy of doxorubicin. So even though it was cardioprotective and it was proven to be so, that it may attenuate the cancer efficacy. So pretty much around the world, it was stopped. It was not used. And then for kids, pediatric cancers, it was also shown to be helpful. But then there was an implication about 10 or 15 years ago that there was a higher rate of secondary leukemia in those people that got desoxane. This was later proven to be false. And so approximately eight to 10 years ago, the European regulatory agency had taken desoxane off the market basically for pediatric cancer, and then they put it back on about 3 or 4 years ago. So at the current time, desoxane is recommended as supportive therapy in pediatric cancer, but as far as I know, the EMA doesn't have an indication for desoxane in adults. In the U.S., the FDA has, generally approved desoxane for patients with breast cancer who have gotten more than 300 milligrams per meter squared. So in your case number 2, she didn't have breast cancer, but she had gotten more than 300 milligrams per meter squared. And I would certainly have appealed to use desoxane at the time. I do think that somehow she must be pretty resistant because, she recovered from subsequent pregnancies with really overall normal ejection fraction, despite very high lifetime doses of anthracycline.
Sure.
So I mean, this is a really interesting challenge.
Yeah, and totally agreed with your nice comment. This is what our patient didn't receive this drug, and we want to explain. I mean, maybe we are discussing this case just to highlight the natural history of cancer therapy and peripartum cardiomyopathy and the subsequent pregnancy. Maybe have evidence, or maybe collecting more case series to have some evidence, at least to we have solid base to have some recommendation for patient with peripartum cardiomyopathy and cancer, and the good and important question about what about the subsequent pregnancy. And for that, we would like to hear from you and from our colleagues about this 2 cases, and we shared any idea about this very important topics, I think.
Yeah, I mean, I think the whole issue of postpartum cardiomyopathy, if you do that, or if you look at that in a non-cancer population, then for the most part, we don't know the cause, and we don't really know how to diagnose it. Basically, we say if somebody has a cardiomyopathy after delivery and there's no other reason identified, then we call it postpartum. But at a minimum, you would say pregnancy and delivery is a stress. So in somebody who had previous anthracycline and you are exposed to an additional stress, you may unmask a mild cardiomyopathy and make it more severe because of that stress. So I don't know if I would necessarily really consider either one of these cases as true postpartum cardiomyopathy. I think it's probably just unmasking a previous mild cardiomyopathy from the anthracycline. I mean, that's just my thought, but I don't think anybody really knows.
Yeah.
I don't know if there are others.
This is yes, we would like to hear from other if it's nicely.
May I I have a question.
Yes, please.
I'm Miss Maria, Bari, Italy. Congratulations for your wonderful presentation and for these cases. I would like to know if did these young ladies receive also radiation therapy together with the anthracyclines at the time of Hodgkin lymphoma, and I would like to know if at that time did they have some cardiovascular risk factors. Thank you.
Thank you for this very nice question. Unfortunately, I could not answer all the questions because we have no registry database for electronic database for our patient, and we see our patient later on with some document, not all the document. I think this is the 18 years. I think there is no evidence of any hypertension or diabetic or any other risk factor for per se for this youngest female. About the radiation, actually, I didn't know if they receive radiation or not, and this is very important question. Totally agreed with you because radiation may be presented with LV dysfunction, but I think the radiation onset of radio therapy affect the LV dysfunction remote rather than and need more duration, but it could happen earlier. It's clear, and I will ask my patient later on, and if any have any data, I will update this very nice issue. Thank you for this question.
Thank you very much.
Professor Farhan. Yeah, Professor Farhan.
Is there any more opinion about what we got? Because there is a link. A recent study make a strong link. Thank you. Link between cancer and peripartum cardiomyopathy, and I will highlight some recent study. But if we would like to hear more from our audience about what they think about this case, it's real anthracycline related LV dysfunction, and after our patient exposed to the stressful multiple subsequent pregnancies, or maybe it could be a peripartum cardiomyopathy, and keep in mind, is there some link between the cancer and future peripartum cardiomyopathy?
Professor Farhan. Yeah, I'm
yes,
Dr.
Please.
Iqbal from Sri. Yeah, I'm Dr. Iqbal from Sri Lanka. Yeah, congratulations,
yes.
Very nice presentation. Yeah, I want to know about the case number 2.
Yes.
At one point, her ejection fraction has dropped to 25%.
Yeah.
Then it's obvious already this cardiomyopathy, it's irreversible damage has occurred. But
yes,
it's remarkably her ejection fraction improved to more than 60%.
Yeah.
I think it could be. I don't know how it is this much improvement happen after an. That is one question.
Yes. Let me answer the first question, and then we have the second question. This is very nice remark from you. As we know, the anthracycline LV dysfunction, the late onset may be permanent and not transient, while keeping in mind 40 to 60% of cases of peripartum cardiomyopathy may get recovery and complete recovery after 6 months or even up to 1 year. And this properties, or this is patient characteristic, maybe make us thinking about the history of peripartum cardiomyopathy in such case, case number 2, rather than permanent LV dysfunction related to the anthracycline. What's your opinion?
Yeah, it could be. It's not solely due to, because even with high dose of cumulative dose, it's almost he has received more than 660 milligram per meter square. It's unbelievable. I don't know how it was given with this cumulative dose. That's why I ask this question. The second question is before chemotherapy, we didn't mention, I think, a record about the cardiac function before the starting anthracycline. I don't know, I missed that, or it's...
No, thank you. I told you that we have no electronic data registry, unfortunately, in our patient, and our patient just bring their documented and maybe missing this document for initial echo before chemotherapy. This is very important, but unfortunately, we have in the initial database.
Okay, thank you.
Thank you again. Okay, we can proceed if no more audience opinion about the discussion, and we have maybe make idea sharing or have more input from our audience and from Daniel.
So this is Joe.
Discussion.
I make two comments, possible.
Yeah. Okay.
Yes, I think it.
Yes, please.
Yeah. So first of all, thank you for doing this, because I don't think we've ever talked about this topic in this group. So I thank you, and I appreciate the care that you guys have delivered to make these patients safe. I just have a question about nomenclature. I think that this is a different entity than the typical postpartum cardiomyopathy, and this is really pregnancy-induced cardiomyopathy that's probably related to chemotherapy. And I think that what you've really taught us is that I mean, we're very often asked to say, can this person get pregnant after they've had high-dose anthracyclines? And I think you've shown us that you can, and we are really pretty vigilant about monitoring fluid status and taking people through the third trimester and delivery to make this be done safely. But I think you've demonstrated very nicely that can be done.
Okay, thank you. I think the question for this comment will be coming in the next slides, so I will proceed for discussion. Thank you for your all remarkable notes. Anthracycline cardiomyopathy is a cancer drug-induced cardiotoxicity leading to more than 10% reduction in LV ejection fraction to value less than 50%, and or GLS more than 15% relatively percentage drop from the baseline, which may be suggested risk of cardiotoxicity. The incidence of anthracycline cardiomyopathy is dose dependent, with total cumulative dose 400 milligram, maybe 5%, 500 raised to up 16, and 700 milligram per meter square raise the incidence of anthracycline cardiomyopathy up to 48%, and this is clearly its high rate of anthracycline cardiomyopathy in patients receiving more than the cumulative permitted and cumulative dose reaching to 700%. Late onset anthracycline cardiomyopathy after 1 year, which chronic progressive cardiotoxicity is more common clinical significant presentation than acute onset, which could be occur within 1 week after treatment. Peripartum cardiomyopathy, on the other side, is an idiopathic cardiomyopathy with LV dysfunction and ejection fraction less than 45% toward the end of a pregnancy or in the months following delivery. Peripartum cardiomyopathy is a diagnosis of exclusion and should be differentiated from other causes of cardiomyopathy-related pregnancy, like anthracycline cardiomyopathy or stressful condition Takasato syndrome. Main risk factor in peripartum cardiomyopathy is hypertension and preeclampsia, which are coexisting with peripartum cardiomyopathy by 47% and 29% respectively. Other risk factors include advanced age, multiparity, and twin gestation. Early recovery of LV dysfunction at 6 months vary widely in different countries and geographical area, and ranging from 46 to 63%. On the other hand, data about the LV ejection fraction recovery between 6 and 12 months is still lacking. Subsequent pregnancy in peripartum cardiomyopathy patient with poorly recovered LV dysfunction ejection fraction less than 50%, holding high risk of relapse, risk of fetal death with 40 reaching to 100% maternal cardiac event rate. While in patients with partial or fully recovered LV dysfunction more than 50%, there is substantial risk of relapse with usually good fetal outcome and make the maternal cardiac event ranging between 19 and 27%. Making a comparison between two conditions, the onset and the presentation of intracycline cardiomyopathy is predictable based on the total cumulative dose of intracycline received, while the onset of peripartum cardiomyopathy is highly unpredictable, except in case of subsequent pregnancy. However, the precise mechanism of both intracycline cardiomyopathy and peripartum cardiomyopathy is incompletely understood. Currently, efforts are paid toward early detection and prevention of both conditions using cardiac imaging and biomarker rule. Maybe have in future or recent study to engage the cardiac imaging modality, cardiac CT, or cardiac biomarkers to differentiate or give guide to diagnose which is which from these conditions. A recent article published in Cardio-Oncology, JACC, recently, 2019, increased cancer prevalence in peripartum cardiomyopathy. And this illustration potentially connection among cancer therapy, and genetic predisposition for cardiomyopathy and patient of cardiomyocyte or the rearrangement and with cancer or affect the cardiac cycle. From other genetic predisposition role for pain and with peripartum cardiomyopathy in patients. The hypothesis of the role of cardiotoxic cancer therapy and genetic predisposition in the development of peripartum cardiomyopathy with history are supported by hypothesis of peripartum cardiomyopathy induced by hypertensive disorder during pregnancy was found in our case series patient, as both of them had no any history of hypertension disorder before or during pregnancy. We have to look for the predisposing factor for peripartum cardiomyopathy, hypertension, or preeclampsia, or twin pregnancy, multivariate. All this factor can predictor factor for peripartum associated with the cardiomyopathy in pregnancy. Another nice article, common genetic predisposing for heart failure in general and cancer, and I think recently many of study and cellular level or a preclinical or even clinical to have a link between the genetic predisposition for heart failure and cancer. This figure shows the link between the cancer and cardiomyopathy, and even the radiation, potential cardiotoxic therapy and other oncology treatment can hit the heart from one side, while the cardiomyopathy associated genetic variant and genetic variant in DDR gene may be give the predispose for cardiomyocyte the dysfunction, and then maybe get cardiac stress and have pregnancy related cardiomyopathy. Regarding the anthracycline related LV dysfunction, measuring only LV dysfunction ejection fraction detected changes that may early be irreversible at the time of the diagnosis. Advanced imaging techniques such as echo-derived measurement of GLS, cardiac MRI maybe detect the early stage of cardiac dysfunction and predict future anthracycline-related LV dysfunction. Another articles related to the pregnancy and cardiomyopathy after anthracycline in childhood. This is a very nice article. The cardiac outcome of a pregnancy in childhood cancer survival must be considered in view of limited data guideline for pregnancy planning, management, and monitoring after cardiotoxic cancer therapy have not been established. This review summarized the limited data available on the topics of pregnancy after anthracycline in childhood, especially after the prolonged survival of many patients receiving optimizing chemotherapy and maybe is reaching the childbearing age. This article have the comparison between 4 studies. The Par-Ital study, this is a prospective study. The total patient was 37, and the conclusion, pregnancy did not cause heart failure in those with normal baseline function. Pregnancy did not increase risk of cardiotoxicities. The second study by Van Dylan, it was a retrospective study, 53 patients, and the conclusion, no heart failure occurred. Study was not powered to assess risk. The third study by Hines and et.al., it was include 847 patients, and the author conclude that the pregnancy-associated cardiomyopathy in childhood cancer survival was low but not insignificant, and give percent from 1 to 500 to 1 to 3,000, 4,000 in general population. And the last study, it was retrospective, 58 patient subgroup identified with increased risk, and this is maybe it's important to consider in our daily practice. Young age at time of cancer diagnosis, longer time from treatment to pregnancy, higher anthracycline dose. What was that in our second case? Pregnancy was an independent risk factor. Cardiotoxicity of anthracycline. And actually we have, this is a very nice diagram to deal in our daily practice in cardio-oncology patient. Starting with primary prevention, detection of subclinical LV dysfunction, and treatment of symptomatic heart failure. Primary prevention, it's need to focus on cardiovascular risk factor control, and initial risk stratification is very essential step in dealing with patients with cancer therapy. Limited anthracycline, use anthracycline analogous, liposomal anthracycline, dexamethasone, and beta blocker, and RAS inhibitor, and statin. This is the essential steps for primary prevention of LV dysfunction-related cancer therapy. While to detection of preclinical cardiotoxicity and prevention of LV dysfunction, we need to use biomarker, maybe troponin. If there is an increase in troponin, maybe indicate myocardial cell injury, and that's we need to use or start our patient with enalapril to protect as cardio protection from LV dysfunction. And if there was or there decrease in GLS, maybe give hint to myocardial deformance, and this is maybe need to add beta blocker for this patient. Still, our patient asymptomatic cardiotoxicity would decrease LV ejection fraction, so we can add ACE inhibitor or beta blocker. And if we have over cardiotoxicity and symptomatic heart failure, ACE inhibitor, beta blocker, and diuretics, and close monitoring, and maybe need more discussion between the cardiology and oncology to maybe have modulate or modify the treatment protocol. In conclusion, we reported 2 patients with history of Hodgkin lymphoma before the diagnosis of peripartum cardiomyopathy, and patients were followed up during their frequent subsequent pregnancies after the diagnosis of peripartum cardiomyopathy with 2 different scenarios. However, the outcome in both patients were successful and uneventful. Still, there is a gray zone to differentiate whether their cardiomyopathies were related to the pregnancy or cancer therapy. Therefore, large observational study registries are required to approve that and to bridge its gap in our daily clinical practice knowledge. Using advanced imaging modalities like cardiac MRI and biomarker for a precise diagnosis is essential in our daily practice. And thank you, and I'm happy to have your comments or your idea, and thank you for your nice listening.
Great, thank you. Thank you so much for an outstanding presentation. There are a couple of issues that you brought up that are probably worth mentioning. Number one, on the first patient,
yes.
At the end of all her pregnancies, etc., she had evidence of mild LV dysfunction, and at one point or another, her LV function got worse, borderline. And so,
yes.
So I think that, the question comes, does this patient require long-term LV dysfunction-based therapy? So obviously during a pregnancy or when she's breastfeeding, you can't use an ACE inhibitor or ARB. So you'd have to switch to something like hydralazine temporarily, but when she's not pregnant or not planning on pregnancy, then she should probably be on lifelong ACE inhibitor. That would be my contention, even though she's only 25 years old, but she clearly is susceptible to LV dysfunction and would need to be protected. And then in the second case, she ended up at one point with severe LV dysfunction that thankfully recovered. The question would be, does she require lifelong therapy or at least extended period therapy? I mean, I don't know. It's a little more difficult in that case because she fully recovered.
Yes. Thank you, Daniel, for this nice remark. I think your question regarding the second case, I think this is the gap in current guideline. We didn't found at time being and currently guideline answer this question, and maybe just individualized medicine and expert of the treating physician and risk factor of the patient. To me, the patient have exceeding the cumulative dose, and the young patient and subsequent for multiple risk factor, at least basically she need close monitoring. And maybe is there any role for any biomarker detection or GLS follow-up? But to me, I will keep the patient for cardio protection. This is from my side, and I would like to hear from your side what you suggest to.
Yeah, I don't know if any others have a thought on that. Definitely, first patient I would keep on lifelong therapy. Second one,
sure.
Second one, I don't think I would necessarily, but I would certainly feel she's at high risk for the development of LV dysfunction in the future because of her anthracycline dose.
So at least, okay, they need close monitoring for the second patient, keeping in mind we might need cardio protection. This is for the second case, and I totally agreed. For the first case, it's not reaching the full ejection fraction recovery. And in addition to that, it's not simply just the ejection fraction, the patient symptoms, the patient risk factor, the patient profile, and I think she need to keep on long lasting cardio protection or cardiac treatment rather than cardio protection. Okay. Is there any more?
I am from Iraq. I'm a cardiology clinical pharmacist working with Prof. Hasan and Farhan. I have two comments for Danielle about the case 1 and case 2. Regarding case 1, using ACE inhibitor and ARAP. Actually, there's you can say the recommendation for breastfeed cessation in patients with peripartum cardiomyopathy, as it may associated with increasing metabolic process and may worse LV dysfunction. According to 2018 ESC guideline for the management of cardiovascular disease during pregnancy, among the recommendation class 2B, use bromocriptine postpartum in patients diagnosed with peripartum cardiomyopathy, as they believe and accelerate LV dysfunction. Therefore, in practice, we advise patients not to breastfeed her babies. Regarding case 2,
so you look at where the catheter is generally in relation to the spine. You can't really see the spine.
Sorry.
No, I think it was interference. Continue.
Regarding case 2, after recovery, should we keep patient on antifailure or not? During searching about evidence, some evidence recommend to keep patient on antifailure, beta blocker, and ACE inhibitor for 1 or 2 years after recovery. And this is what we are doing in our daily practice. And we demonstrated that in a figure which was published in a chapter in a book for Prof. Karen Sliwa about peripartum cardiomyopathy, which released in January this year. So more details you can find in this chapter about how to deal with the peripartum cardiomyopathy for long term.
Great. Any other questions out there or comments?
I have a comment. This is Prince Ochiri. I think the second case is interesting. As we said, the EF went from 25 to 60%. And I think there sometimes can be a disconnect between the basic science, what the histology is showing, and when we do this epidemiology studies, what we may find. So this patient went through a stress test, which is pregnancy, and that really showed the dysfunction that has happened, histologically, that we were not seeing. So 10 years down the line, hypertension, other things happen, coronary disease, other risk factors. This patient definitely will have a higher risk factor, higher risk of having EF decline than other patients. This is a patient that I personally would think that would need cardioprotection, because we know that stress test, she had EF decline and likely will have it in the future. That's my comment.
Ron, you're unmuted. I don't know if you have a comment or a question.
Oh, thank you. Actually, I was thinking, I just want to congratulate our speakers, because this was really a very useful conversation. And also I tend to agree with the last speaker in terms of the fact that when you do have a damaged heart, you definitely, it seems like you don't respond to stress. And I think that's one of the things we see with TKI inhibitors also, and that is that unless you protect them from the stress, they will decompensate. And so I think there is a good case to be made for some sort of long-term either monitoring or even potentially prophylactic protection. Certainly in the first case, there's no question you're treating heart failure. That's clear. The other question I would have in my own mind, and I don't think we can answer it, is whether or not an MRI would show a difference or some long-term damage to the ventricle. I'd expect it would, but again, we don't know that, and that might help you influence your therapy long-term. But anyway, thank you. It was a wonderful presentation and a great choice of topic.
Great, thank you so much. Now, really impressive. These are challenging decisions, and you guys had to make them at the moment. So it's always difficult to do those things, and then replaying how things went it seems quite simple, but while it's happening, it's definitely not. So I appreciate all the complexity that you have there. All right, well, thank you all so much for your attention, and we really congratulate our Iraqi chapter for a great presentation, and they're very proactive and careful management of these difficult patients.
Hasan, your microphone is muted if you had any last comments.
So Steve, do you know what we have for next week?
Yes, our imaging working group will present another case related to, I'm not sure exactly which modality, but it'll be imaging and cardio-oncology again.
Great. Thank you all so much. Have a great day.
Thank you.
You as well. Thank you.
Thank
you. Goodbye.
Bye-bye.